For today's session, we have Dr. Devendra Chokar with us. He's the Director of Head Neck Services at Max Hospital, Nanavati in Mumbai. And he'll be speaking upon the role of neoadjuvant chemotherapy in oral cancers. So you may please share your screen. Hello.
So good evening, everyone. Today's topic is role of neoadjuvant chemotherapy in oral cancers. The next 20 minutes, we'll just discuss a few things on what importance neoadjuvant chemotherapy has in oral cancers. Next slide, please. You'll have to move from your end. Yeah, so neoadjuvant means the word neo is from a Greek word and adjuvant is from a Latin word. It means new and adjuvant means to help. So what basically neoadjuvant chemotherapy is all about is to help definitive or subsequent local therapy. So it can be most of the times in oral cavity. It constitutes as definitive. Give me 1 minute. Call come. Right. So systemic therapy given before local therapy is what neoadjuvant therapy is about. And in oral cancers, it is usually given before surgical intervention with the hope of increasing local control, long-term outcomes, and lesser resections or improving quality of life of patients. Next slide, please. So the advantages of giving chemotherapy before treatment is that the vasculature is intact, the vasculature of the tumor is intact, so there is better access of all the chemotherapeutic drugs to the tumor, so it will act better. And it may reduce the burden of, we give it in the hope that reduce the burden, tumor burden, with which makes local treatment more effective. Decrease in the tumor size will, in some cases, especially locally advanced tumors, will allow you to get good margins. And we hope that decreasing the tumor may allow you to preserve the organ or at least reduce the intensity of adjuvant therapy. And all these hypotheses we'll try and test with what studies have been done in neoadjuvant chemotherapy in oral cancer. Next slide, please. The disadvantage of neoadjuvant chemotherapy is that it is toxic. So your subsequent definitive therapy may get compromised if you get toxicity because of the neoadjuvant chemotherapy, and you may compromise on survival. If it is ineffective, which happens in about 10 to 15% of the patients, then your disease, you've lost that time frame and the window for treatment, and the disease may actually grow, and you'll lose on the definitive treatment. And also there are concerns that just like radiation, it may impact wound healing. And the bigger concern is that it obscures the pathological staging, because suppose you had a node which was positive and becomes negative later on, or the tumor disappears, then there's a big question of what to do. What will you excise? What adjuvant therapy will you give if there is a pathological response to neoadjuvant chemotherapy? So these are some unanswered questions in neoadjuvant chemotherapy, and we'll look at them one by one as we go on. Next slide, please. So coming to oral cancer, which is the topic of today, as all of you know, oral cancer surgery is the mainstay of treatment. And the problem with oral cancer, though, is 70% are in advanced cases, and the prognosis of these advanced cases is poor. Whatever you do currently with the treatment of surgery plus minus radio or chemoradiation therapy, 50% or 60% will recur locally, and another 15-20% will fail at distant sites. So to increase the intensity of treatment in these bad risk tumors, or what we call as locally advanced tumors, there was the thought that we should add chemotherapy as a neoadjuvant strategy to increase or improve local control. And this started because they were getting encouraging results in the 70s and 80s with cisplatin. And when you added 5-FU, the response rates even went up further. So there was a good amount of enthusiasm that maybe giving chemotherapy before local therapy will improve outcomes. Next slide, please. And because of this, there was the first trial which was done by Lisa, etc., way back in 90s, reported in 2003, the JCO. It was for oral cancers, T2 to T4, N0 to N2, M0 disease. Next slide, please. A very simple design. One arm received NACT followed by surgery, and the second arm received upfront surgery as was planned for resectable oral cancers. Next slide, please. But the problem was this was a negative trial. There was no difference in both the arms. There was no improvement in survival with the NACT arm, even in overall survival or event-free survival. Next slide, please. That's the Kaplan-Meier curves of both the arms, which are overlapping, and there was no difference. So a negative trial overall. Next slide, please. This was the 10-year follow-up of this data, which again did not give us any difference in DFS or overall survival, telling us that probably cisplatin 5FU doesn't work in improving overall or disease-free survival. Next slide, please. However, there were two hypotheses that were generated by this trial. One was in the NACT arm, the number of mandibles that were resected were less. It was 31% in the NACT arm and 52% in the control arm. So that was one hypothesis, that maybe giving neoadjuvant chemotherapy decreases the size of the disease and you have to resect less. That's number one. Number two was in patients who received NACT. The final histology report did not mandate post-op RT. It was 33% in the NACT arm and 46% in the control arm. So there were lesser patients who mandated post-op RT. And then the hypothesis that generated from this was that maybe you can scale down on the adjuvant therapy by giving neoadjuvant therapy and sterilizing the field. These are just two hypotheses generating principles from the Lycitra trial. Next slide, please. What happened in the meanwhile was we were getting better and better drugs, and oncologists added docetaxel to cisplatin and 5FU. And the stacks 323 and 324 were designed to look at 3-drug regime versus the 2-drug regime. And what they told us was when you add docetaxel or taxanes to the cisplatin 5FU, the response rates are even better. And this again rejuvenated the trials for NACT. Next slide, please. And so researchers felt that cisplatin 5FU, if we add docetaxel, maybe that was what was lacking, and we'll get better responses and maybe better survival rates. And that was the trial. Again, a randomized phase 3 trial by Zong. Next slide, please. So again, histology confirmed oral cancers, stage 3-4. Next slide, please. He randomized 256 patients. Again, the trial design was exactly the same. Experimental arm consists of NACT, 3-drug regime this time, and the control arm was upfront. Exactly the trial design that Lycitra did. Next slide, please. But the dose of cisplatin and 5FU was slightly different. In Lycitra's trial, they used 1,000 and 750. 100 and 1,000 for cisplatin and 5FU. Here, because they added docetaxel, they had to scale down on cisplatin, which was 75 milligram per meter square, and 5FU was 750 milligram per meter square instead of 3 drugs. But this was a 3-drug versus the 2-drug of Lycitra trial. And exactly 2 cycles were given every 3 weekly. Next slide, please. So the response rate was encouraging. We had almost partial plus complete was almost to the tune of 80%, which was quite encouraging, and which is what they expected in the 3-drug regime. It is much better than what you get in the 2-drug regime, which is about 65 to 70%. Next slide, please. However, even this trial failed to show any difference in overall or disease-free survival. Again, the trial was negative. Neoadjuvant chemotherapy did not add or did not improve local control or overall survival. Next slide, please. But when they did a subset analysis for locally advanced disease, a slightly more advanced set of disease, the N2 disease, what they found was, it was not designed to look at this, but they did a subset analysis. And what they found was probably in patients who had larger tumor burden, more tumor burden, maybe neoadjuvant chemotherapy may work in this subset of patients rather than clubbing up the entire subset of stage 3 and 4 patients. If you look at very advanced local disease, maybe neoadjuvant chemotherapy make a difference. And they saw that it is making a difference for N2 disease in overall and disease-free survival. Next slide, please. So, of course, the logical step is then, if you have two or more randomized trials, is then to do a meta-analysis. And this was done for both these trials, the long-term Bossi Lycitra trial and the Zong trial. Again, this failed to show a difference for neoadjuvant chemotherapy in terms of overall survival. So neoadjuvant chemotherapy did not add to overall survival, even in this meta-analysis. Next slide, please. But again, this meta-analysis looked at a subset of patients who were N2 patients, and again there it seemed to make a difference. Next slide, please. So the story so far that we have seen is NACT did not make a difference for overall survival or disease-free survival in all operable oral cancers when you take it as a group. But in a certain set of operable, so 3 hypotheses we have generated so far. One is that if you have a large burden of disease, the N2 disease, and maybe the T4B disease, that didn't come out earlier, but that's if the burden is larger, then maybe neoadjuvant chemotherapy may play a role in improving survival. Second hypothesis was the Liciter hypothesis that giving neoadjuvant chemotherapy may decrease your extent of dissection and maybe allow you to do organ preservation. And the third hypothesis that we have generated from NACT trials is that you can reduce or probably reduce the intensity of adjuvant therapy. So let's look at these. Let's look at some of these, whether these hypotheses have been further tested. Next slide, please. So advanced disease. Let's come to what's advanced disease, right? There are 13 different classifications, 13 or 14 different classifications which talk about advanced disease from T1 N1 to T3 N3 and so on and so forth, T4 N3, so on and so forth. So next slide, please. The different definitions of advanced or operable oral cancers. Of course, inoperable, we know, carotid, prevertebral fascia, high internal pterygoid plates, that's there. But there is a set of patients who are not strictly inoperable by this definition, but the surgeon don't think that in this large volume disease, they may get negative margin. So out of these definitions, there are 2 definitions that you take home for operable disease. One is the ability of the surgeon to achieve a negative margin. And 2 is to give a functional and meaningful reconstruction. If you can satisfy these 2 criteria, then you call it as operable oral cancer. Otherwise, there is a term which is used which was coined by a group at Tata Hospital. Next slide, please. Which called this borderline operable. That means the surgeon is unsure whether he's going to get a positive margin. It may be compromised sometimes when the disease goes up into the infratemporal fossa, disease of the tongue going back towards the hyoid, where you probably will not get a margin. Or sometimes you have edema of the zygoma, which is edema of the cheek, which goes up to the zygoma. So these 3 areas, the surgeons were looking back at the results and seeing that these are the 3 areas that probably are compromising on margins and the outcomes are not so great. And hence, this was one of the hypotheses that was generated in the earlier neoadjuvant trials. And then we said, why not try neoadjuvant chemotherapy in these set of borderline operable tumors? Next slide, please. And this was a retrospective study from Kumar Prabhash and Vijay Patil's group. 721 patients, 310 out of the 721 patients which received chemotherapy, they could operate 310. Almost 43% of the patients underwent surgical resection and went on to receive appropriate adjuvant therapy. And those who could not get a good response, and surgeons still felt after neoadjuvant chemotherapy that the margins are still maybe positive, they went on to receive alternative therapies such as chemotherapy, palliative, or chemoradiation therapy. Next slide, please. And those who went on to receive surgery, what we saw in this trial was, or this retrospective data, was that those who went on to receive surgery, that means those who responded to chemotherapy, did better than those who had non-surgical options. So in this group of patients, which are very advanced, maybe technically unresectable. Of course, it is a very individual term, technically unresectable. What is resectable to me may not be resectable to somebody else, and vice versa. But this was the definition of these 3 things. We saw that neoadjuvant chemotherapy was probably making a difference in 2 ways. One, it was downstaging the disease. We were more confident of getting negative margins. And 2, it was helping us probably select the patients which had a better biology. We all know that patients who respond to neoadjuvant chemotherapy do well with subsequent therapy. It was helping us triage patients. So this was the hypothesis which was generated earlier on, which was then tested in a retrospective study. Next slide, please. Again, there are a subgroup of patients who are T4 to begin with. Next slide, please. And if you look at the earlier 2 trials, the Bossi trial and the Zong trial and the Liciter trial, they include patients with stage 3-4, but majority of the patients was T1 to T3. So we could not extrapolate these results to T4 cancers, which many of our patients have T4 cancers. So because of the hypothesis that N2 disease, large volume disease, NACT may work, we thought that why not test it or look at our T4 cancers specifically as a group, which are higher tumor burden, and look at what is NACT doing in these cancers. Next slide, please. So this was a retrospective study done by Dr. Shiva at Tata Hospital, where they looked at outcomes of T4 oral cancers between patients who had NACT and those who went for upfront surgery. Next slide, please. So this was inclusion criteria was only T4 disease, NE and M0, squamous carcinomas who went upfront surgery or had NACT followed by surgery at TMH. Next slide, please. When you look at the results, T4B was doing better with NACT, especially if it was tongue cancer, if it was skin involvement, but bone involvement was not doing as well. So if you had bone involvement in T4, then upfront surgery was doing better as opposed to skin and tongue cancers. Next slide, please. With overall survival, also T4B was slightly doing better with NACT. Again, reiterating the fact of that hypothesis which was generated by the ZONG trial that more disease, larger burden of disease, N2 disease, T4 disease, maybe chemotherapy may have a role in treating these patients. Next slide, please. So clearly what was seen in this trial this study was that NACT had an advantage in terms of recurrence in T4B, especially those who have skin and tongue involvement. If you have bone involvement, it's better to do upfront surgery. NACT will not add to any benefit. And in terms of overall survival, T4B, not T4A, but T4B, there is a bit of a survival advantage. Of course, these are retrospective studies. You will need prospective data to prove this hypothesis of higher nodal disease, higher tumor burden at the primary site, whether NACT in this set of patients, not the entire gamut of stage 3-4, not the T2, T3s, the T4s, the N2s, whether these patients are going to benefit with NACT needs to be tested in the prospective study. But these are what is the hypothesis that is generated, and there is some retrospective study to tell us that it's worth pursuing these cancers with treating with NACT. Next slide, please. What are the issues with NACT? You give NACT to operable patients, you give NACT to locally advanced patients. One is the response assessment. Most of these patients will come back to you with a scan with clinical response, but the scan showing almost exactly the same disease. The RECIST criteria shows it's stable disease. Second is, what about margins when you do surgery? What margins will you take? That's an unresolved question. Anuja was working on it. I don't think she has published it yet, but that will soon come out. What do you do with margins? What margins do you take when there is a response? And third, does chemotherapy increase complications? Well, we look at each of these. Next slide, please. So we all know the RECIST criteria of complete response, those who have complete disappearance, partial more than 50%. I'm sorry, this is wrong, but we know the RECIST criteria. Next slide, please. And what study shows us was that, RECIST criteria is a unidimensional imaging and volumetric changes are not included in the RECIST criteria. Next slide, please. Next, just tap. Yeah. So when you look at this trial, go back. When you look at this trial, just go back one. Yeah. When you look at this trial, 8.1% of CR by RECIST criteria, there was a 13.4% achieved pathological response. So obviously the pathological response was more. You see something on radiology that tells you it's stable disease, but there's a pathological complete response. Next slide, please. Again, when you looked at this study from Amit Joshi and Vijay Patil et al. Told us, next slide, please, that 35% of patients who had stable disease as per RECIST underwent surgical resection. That means that there was a good clinical response. The surgeons thought he'll get a negative margin. So obviously the RECIST was not doing as well in oral cavity cancers. And we need to have, there are some shortcomings, but this is the best method we have today. But we need to modify our RECIST criteria because you will have clinical response, but you may not have as good radiological response. So you have to marry the two and take a call for surgery. Next slide, please. So the positive negative predictive value of radiological response is less than 50% if you compare it to pathological response. So clearly the RECIST is not doing too well. You have to take a call based on a clinical judgment and your clinical response rates and not look at radiology to that extent, because even stable disease sometimes has good pathological response. So that's as far as response assessment goes. We need a better tool to look at the volumetric analysis, not only unidimensional imaging that is done for RECIST criteria. Next slide, please. The other two that I mentioned was margins and complications. Well, if you look at all the studies, Licitra study, Zong study, and the study that I'm going to quote that came out of TMH for organ preservation, where we operated as per new margin, there was no difference in margin positivity. There was no difference in local control. So clearly, that old concept of operating as well, of course, you go a little wider, but that old concept of going as per original margins, you really don't know after neoadjuvant chemotherapy unless you tattooed the margins. What was the original margin? But overall, after surgery, you're not increasing the rate of positive margins or decreasing local control. That is what has come out from all the studies, all retrospective studies out of Tata, Licitra study, Zong study, and the TMH study of organ preservation, that the margin was not compromised. So that's number one. Number two, Kumar Prabhash did report a slightly increased rate of complications in patients who had undergone NACT. But of course, these patients, as compared to patients who underwent surgery, but of course, these patients are a set of patients which were really locally advanced. The sections were major, bigger, and the reconstruction was bigger. So yes, they had, but it did not translate. The complications did not translate into decrease in or increase in the time for adjuvant therapy. So all patients completed their definitive treatment in set, and the local complications that were slightly higher in the NACT arm did not impact on the post-operative complications. Next slide, please. Now, finally, coming to the last hypothesis that we have is of organ preservation. That was the Licitra's hypothesis. Well, the final hypothesis of whether you can decrease adjuvant therapy has not yet been tested. We are currently running a phase 3 in Tata. Before I left, we have started this trial, organ preservation, where we stratified patients post-operative depending on the pathological response. And for this trial, the phase 2 trial that I'm just going to present, we had kept CTRT for all patients, considering that because you take new margins, slightly there may be tumor, and considering its positive margin, we gave CTRT to everyone. So that hypothesis of whether we can decrease adjuvant therapy has not been tested, but this is the hypothesis, the second Licitra's hypothesis, that can be decreased excision or amount of this that we decrease excision that we do, that was tested, and that's what I'm going to present right away. So tumor shrinkage permitting lesser resection. Next slide, please. So this was the trial, a prospective phase 2 randomized trial of upfront surgery versus neoadjuvant chemotherapy followed by surgery. This was reported in the ACO a couple of years ago. Next slide, please. Again, a simple trial design. The basis was that we looked at retrospective studies and looked at that if when we are removing mandibles, which are not grossly involved clinico-radiologically, only 40% were showing involvement. All the mandibles that were resected, 40% showed. So we were removing mandibles for paramandibular disease, and 60% were free of tumor. Next slide, please. So that was the question in front of us. Can some of these mandibles, not all, but can some of these mandibles be preserved and prevent unnecessary mandibular excision? Because of course, we have a free flap, we can do fibula, but it's labor intensive and it also costs a lot of money. If you can save the normal anatomy, that's the best cosmesis that you can get. So that was the question in front of us. Next slide, please. So we designed this trial, a phase 2 study, which looked at the role of NACT in mandible preservation. Next slide, please. The primary aim was to preserve continuity of the mandible, and the secondary aim was to compare quality of life and toxicity and local regional control. Next slide, please. Again, a simple trial design. We randomized as per Licitra standard arm, who are patients who had paramandibular disease requiring segmental mandibulectomy, appropriate post-operative depending on the histopathology. In the intervention arm, we gave 2 cycles of 3-drug regime, reassessed the patient, and the individual surgeons operated the patients as they deemed fit, trying to conserve the mandible if possible. And then we gave adjuvant CTRT to all patients, as I said. In the new trial, we are not giving adjuvant CTRT to all patients. We are going to stratify it as per the histology report. Next slide, please. So that's the cartoon. Just keep clicking. That's the tumor which sits behind. Just keep clicking, Asim. The tumor, which paramandibular disease requiring segment to resection. We give NACT, try to shrink the tumor, and then try to do a marginal resection. This is what we attempted. Next slide, please. And this was the complete response. Complete and partial response was the tune of 85%, as we expect with 3-drug regime. Next slide, please. And this is what we got, a large paramandibular disease where we can't save because of soft tissue. You have to resect the mandible. You give 3 drugs. You give 2 cycles of 3-drug regime. You get a very good response. You get a good soft tissue resolution. Of course, the bone was not involved. And here you can do a marginal mandibulectomy. Next slide, please. And the results showed that in 48% of the patients, 16 out of 34, it was 68 patients cut trial. It was a phase 2 trial. Out of the 34, 16 mandibles, we could preserve their continuity. And this did not. Next slide, please. This was not at the cost of margins. So we did not have any close or negative or positive margin in the NACT arm and the local control. Of course, this trial was not designed to look at that, but we looked at our patients and we did not have any difference in local control between the NACT or the surgery arm. So clearly, the hypothesis went one step further to elicit hypothesis and tested it in the phase 2, and the phase 3 trial is ongoing. Next slide, please. So there was no difference in overall survival between the 2 arms at median follow-up of 36 months, I think, and there was no difference in disease-free survival. Of course, there was no increase in local recurrence rates as well. Next slide, please. So in conclusion, today NACT has no role or no survival advantage in operable oral cancers. There may be a subset of patients with large tumor burden, either at the local site, T4Bs, or the N2 diseases, where whatever you do, these guys are going to fail either locally or distant, and that's where we need to test neoadjuvant chemotherapy, not the entire stage 3, stage 4. We need to test it in large tumor burden patients. We need to have a prospective trial looking at NACT in these subset of patients, whether we can improve survival. Organ preservation is an exciting concept. Yes, today it is toxic, but we are improving our delivery, and the toxicity of chemotherapy is coming down. It's an exciting concept, needs to be tested further in prospective phase 3 trials. Borderline resectable is something which is debatable, but when you think you can't achieve a negative margin, but you think this patient is operable, not grossly inoperable, but you are struggling to get a positive margin, that's the time when you want to give NACT. For operable cancers, again, I'm saying you should not give NACT, but patients where you think you can't get a negative margin, try to give NACT, downstage the disease, and those who respond to NACT probably do better than those who don't. And we need biomarkers, of course, to de-escalate and to first select patients who will go to respond to chemotherapy and de-escalate adjuvant therapy in NACT patients. Thank you very much.
Thank you, sir. So are there any questions? You can please share your questions on the chat box. So we will proceed with the
panel.
Yes, sir. So we'll proceed with the case discussion.
Yes, please.
I think Sarvani ma'am has a question on margins.
What is the question? She's only written margins.
Yeah, I know. Sorry. But the thing is that what I want to ask you is, you are talking about, the 2 trials, the Jong and the Recitra trial had used different things for margins. Now, you all say that we'll go by whatever margins. There is a disparity between the trials. So my question is that you may resect less, but usually what happens with the adjuvant, that is the other aspect of de-escalation, is where and how do we take the margins? Because even if you take lower margins, as you said once before, that it is the thing that we usually go back to the older, the pre-chemotherapy margins. So that is the issue that I'm asking you.
So Sarvani, you always go by CT scan in your marking or planning. We go by the clinical response. And even if you look at though we always keep the CT scan in the OT, it's really, when you have a good clinical response, it's really difficult to, unless you've tattooed the margins, to actually go back. All of us in our just because we feel there is good response, instead of going a centimeter, we got a centimeter and a half away. But for a paramandibular, we took good soft tissue cover and saved the mandible, and that did not seem to increase the local response. The answer is not there yet, Sarvani. We don't know whether we can de-escalate yet by giving NACT, but there is some data to say that it's probably possible to de-escalate, even giving adjuvant CTRT versus just giving RT. Now, suppose you probably had a N1 disease which went away with chemo. We don't know whether we can de-escalate therapy. These answers are not there. So, but generally you will go a centimeter and a half wider. I agree with you. Today, all of us want to be safe. The trial that we did, we went as per new margins. and gave CTRT considering that there may be islands of cells that probably have been left behind, but we didn't say any local difference in local control.
There is another question by Ankit.
Breaking up, Sarpani.
No, it's okay. Please go ahead with the next question.
Ankit's question is, no, we did it only for buccal cancers, Ankit. We did not do it for tongue. Some people are trying it for tongue. The only problem was, how do we test how much excision? So that requires functional swallowing assessment, whether after giving NSAT you can preserve more tongue, and the swallowing in patients whom you gave NSAT is better. So I'm sure some of you can do that trial. This was a pure mandible preservation. The disease that we face is the GBS buccal cancers. We didn't have many. I think there was only one floor mouth cancer, if I'm not mistaken, but there were not many floor mouth cancers.
So thank you, sir. So we will proceed with the case discussion now. And for the moderation, we have Dr. Devendra Chokar, sir. So please continue for the case presentation. Dr. Shwetab Sinha, assistant professor in
You have to excuse me for a minute. I'll have to go and continue the case. I'll join in between. Yeah, y'all continue.
Okay,
Yeah.
sir. So we have Dr. Shwetab Sinha. He's assistant professor in radiation oncology at Tata Memorial Hospital, Mumbai.
Hi.
Dr. Sanskruti Murthy. She's assistant professor in Kidwai Memorial Institute of Oncology, Bangalore. And Dr. Satya Sarangi. He's assistant professor in medical oncology at SGPGI, Lucknow. Satya,
Hi.
are you there? Hello, Sanskruti.
Hi.
Good evening, all.
Yeah, good evening. And for case presentation, we have Dr. Devendra Singh. He's a fellow in head and neck surgery at Mahamana Pandit Madan Mohan Malvi Cancer Center, Varanasi.
Yeah.
Hello, good evening to all. I will be presenting the case on a carcinoma of early buccal mucosa.
Yeah, go ahead.
Okay. My patient is a 45-year-old male, shopkeeper by occupation, residing from Gorakhpur, Uttar Pradesh, presented with a chief complaint of ulcer in the oral cavity since 5 months. Coming to the history of present illness, the patient was apparently well 5 months back when he noticed an ulcer in the right buccal mucosa, which was insidious in onset. According to patient, initially it was a size of P, and it has gradually progressed to the present size of approximately 2 into 2 centimeter. The ulcer was associated with pain. It was localized to the site of ulcer, and it aggravated while eating and chewing, and was relieved by the analgesics. There was no history of any sharp tooth, no history of oral bleeding, and no history of any high-risk behavior, no history of earache, no history of similar lesions in the other sides of oral cavity, no history of reduced mouth opening, no history of neck swelling, and no history of any bone pain, cough, or the hemoptysis. To the past history, there was no previously relevant medical history or any surgical intervention of the patient in the past. And there was no history of any comorbidities like diabetes, hypertension, chronic obstructive pulmonary disease, or tuberculosis. On coming to the personal history, the patient is a tobacco chewer for the last 20 years. And along with tobacco, there was no other addiction present. Patient has a normal bowel and bladder habit and a sleep pattern, and no history of any drug allergy. Coming to the family history, there was no any relevant or significant family history. So to summarize the history, a 45-year male tobacco chewer presented with an ulcer in the right buccal mucosa for the last 5 months. It was associated with pain, but only localized to the site of ulcer, which was relieved on analgesics. Shall I proceed?
Yes, you can proceed. I think we'll take the questions in the end. If ever, hello.
Yeah, please proceed.
Yeah. So coming to the general examination, with the prior consent, I've examined the patient in full actual light. Patient is well oriented to the time, place, and person. He is moderately built and well nourished with an ECOG score of 0, with BMI of 21.6 and BP 112 by 70 millimeter of mercury, pulse rate of 74 per minute, and was no signs of any failure, icterus, cyanosis, clubbing, edema, or any generalized lymphadenopathy. On local examination, on inspection, the mouth opening of the patient was 3.5 centimeter with a dentate status, and there was a staining of teeth were present. There was no oral submucous fibrosis. On inspection, there was an ulceroproliferative lesion with an irregular margin and everted edges on the right buccal mucosa, approximately 2 into 2 centimeter. The lesion was well away from the upper and lower gingival-buccal sulcus, but the tumor was anteriorly involving the angle of the mouth. Posteriorly, it extends up to the level of first molar, and no suspicious lesion were seen in the rest of the oral cavity, and none of the any white patches were present in the oral cavity. There were no scar, sinus, fistula in the overlying cheek skin. So these are the images. It is well away from the both upper and lower GBS, 2 into 2 centimeter lesion involving the angle of mouth. So on palpation, my inspectory findings were confirmed with respect to the lesion, that is a 2 into 2 centimeter lesion. Lesion is indurated, and on palpation, the thickness of lesion was approximately around 1 centimeter. However, on bimanual palpation, the skin over the lesion appears clinically free, but was seen slow on palpation. There were no neck nodes palpable, and on skin examination, the rest of the oropharynx, hypopharynx, and larynx were within the normal limits. Coming to the systemic examination, a CVF S1, S2 normal heard, no added sounds. Respiratory, bilateral vesicular breath sounds. Abdomen not distended, soft, no organomegaly present. And on CNS, there was no focal and neurological deficit. All cranial nerves were free. So to summarize my history, a 45-year male, known tobacco chewer for last 20 years, complains with an ulcer in the right buccal mucosa since 5 months. There is an ulceroproliferative lesion in the right buccal mucosa, 2 into 2 centimeter, away from both upper and the lower gingival-buccal sulcus, involving the angle of mouth with approximately thickness of around 1 centimeter on palpation and with the skin closed, and the no palpable neck nodes.
Can you start with the first slide? So what does demographic? So what does a demographic history of the patient tell you? How does it affect your clinical judgment? Can you hear me?
Yes, ma'am. Ma'am, demographic details of the patient, such as the patient is a shopkeeper by occupation. His occupation relieves that the patient is belonging from a low socioeconomic status, and so the habitual history of the patient seems relevant in this oral cavity cancers.
Is occupation, does it tell you anything else more? It will give you a wide, if you, most of the patients who, not every tobacco chewer gets cancer. So if you read other etiology that can cause oral cancer, you have nutrition also one among them. So you have a hard wage laborer who might be nutritionally deficient also. So the occupation, age of the patient in the demographics would be important.
Yes, ma'am.
And can you go to the next slide? So you have a patient who has history of an ulcer which is there since 5 months.
Yes, ma'am.
And insidious in onset. So if this tumor had an aggressive behavior with a sudden increase in size, what are the reasons for the same? Hello, can you hear me?
Yes, ma'am. Ma'am, the patient with a progression of the lesion very fast signifies maybe a higher grade morphology of the lesion, and
Good. Then, hello.
And
Can you
ma'am,
hear me?
yes, ma'am, I can hear you.
Yeah. So initially you have mentioned that it started off with the size of a pea and increased gradually over 5 months. So one is the grade and the aggression of the disease is something that you will know.
Yes.
Then it was associated with pain. So what are the causes of pain in oral cancer?
Ma'am, pain can be due to the first of all on when the location of site is on the buccal mucosa, when the patient tries to open his mouth or while during aggravated while eating or chewing, it may be a local pain due to local inflammation.
Yes. Then
It can be again as a with a oral mucosa with an oral ulcer, patient might not be able to do his routine dental hygiene and oral hygiene. So there may be an superadded bacterial infections which can lead to pain.
then
And lesions with a involvement of a advanced lesions which are involvement of a perineal invasions can present with a pain.
yeah, and in this patient, in usually buccal cancers, the patient bite trauma is quite common. So that will cause recurrent bleeding, infection, and pain for these patients. Same thing with lateral border of the tongue. Even though these tumors are quite early, they do present to us because of the pain that happens because of the trauma, because they're along the bite line most often. Then the next slide. If other moderators can also join in if they have anything to add on. Am I audible?
Yeah, Dr. Samskritik, please carry on.
You can go to the next slide. What do you mean by high-risk behavior? What all did you ask for in high-risk behavior?
Ma'am, I just include the history of high-risk behavior due to for the history of sexual promiscuity, as these kind of ulcers in a 45-year male may represent a bacterial infections from like syphilis. Syphilitic ulcer might have a differential diagnosis for such kind of lesions in the oral cavity, which that's why I have ruled out this history.
Does HIV has any bearing on this patient? If did you ask for that?
In HIV infections, due to the body's low immunocompromised status, there might be a superadded fungal infections like which can or a major immune reactions like recurrent after stomatitis kind of ulcers can present in such patients.
Yeah. So, what are your treatment bearing that diagnosis of HIV has? Especially because you specifically mentioned high-risk behavior for this patient. So, HIV and oral cancer, what all will come to your mind from clinical point of view from and up to treatment bearing? Treatment implications. If this patient was HIV positive, taking it as oral cancer, what else would you ask for? You will ask whether the patient is on ART treatment or not, whether they're taking it regularly or not. You will ask in your investigations, what else will you ask for if the patient has HIV?
For a CD4 count, if patient is on ART or is CD4 count status.
Yeah. What does CD4 count? What does CD4 count tell you as a clinician? So, what cutoff of CD4 count do you consider for surgery and risk for surgery, for chemotherapy also? The patient might have immune suppression later on. So, when you get a CD4 count, what are you looking for? What is the value you're looking for? Anything less than 200, you would consider it as severely immune suppressed. So whenever you put something in your history, make sure you don't lead the examiner into something that you don't want, you are not too familiar with. So as soon as you say high risk behavior, we would probably think of HPV, HIV more than syphilis, which is quite rare these days.
Yes.
Okay, next slide.
Hello. So I just wanted to ask you, you have written here there is no history of similar lesions in the sides of oral cavity. So could you please explain why this history is important?
Sir, as the person is a habitual tobacco chewer, so I just wanted to rule out any other synchronous or any other lesions in the oral cavity. That
Okay,
can
so
be many.
what is this phenomenon called? And what was the risk factor because of which you asked this question?
So this is called as a synchronous second primary. And this factor
That
is
I get it. You are saying ki there could be a similar lesion, but why is it so?
so for the so due to as the patient is a habitual tobacco chewer, there might be the field of the oral cavity, there might be a field cancerization. And so as the
Yes.
all of the buccal mucosa has been exposed to the such carcinogens, so that might lead to, so I have just studied the history of any other similar lesions in the other sides of oral cavity.
Okay, good.
You can go to the
I
next
think you
slide. No, if I'm sorry, I interrupted somebody.
No, I said you can move to the next slide.
Yeah, okay, thank you.
One more thing, would you like to quantify the tobacco usage better, whether the patient is reformed now and what type of tobacco, pack years, everything? At least I think for your exams, it may be better. Just saying that patient has a tobacco chewer for 20 years may be good enough when in your clinical practice, but probably not for your exams.
The patient is a tobacco chewer for the last 20 years. He has been consuming around 5 to 6 pouches per day in a form of a smokeless tobacco. And he has been just reformed from the last 1 month only.
It is also important that you ask them whether the patient has history of keeping a quid or does he keep it in any of the gingiva buccal sulcus. So probably that will give you an idea where, you might have to look for again if there are any other lesions specifically in the area where the patient places quid. So probably you can add that in your history when you, especially for smokeless tobacco.
Yes.
You can go to the next one. No, you can go to the next slide. General examination. General examination. Yeah. So what are the ECOG? What are the ECOG performance status? Grade them.
ECOG 0 is a normal. ECOG 1, a patient can do his routine activity, but on exertion or strenuous activity, there are limited, his activities are limited in ECOG 1. And
ECOG 2.
ECOG 2.
See, basically when we're doing a general. Yes.
He's with strenuous activity 1 and with ECOG 2 is he has limited activity, and 3 and 4 more than 50% and less than 50% of activity has been reduced, and 5 is moribund, bedridden, and 6 is moribund.
See, why do you need general examination where you're talking about patient's build, nourishment, performance status? Why is that important?
Ma'am, for the preoperative screening of the patient and also post-operative rehabilitation of the patient.
See, don't use the term preoperative, because when you're seeing a cancer patient, you don't know what modality of treatment you're going to start. So as soon as the patient walks into your clinic, first thing you will always assess is whether the patient can tolerate the treatment that you give, be it surgery, be it radiation or chemo. So for all three modalities, it is extremely important that you assess performance status, BMI, and the general examination is going to play a big role. So that itself, if you see a patient who's coming in a wheelchair or is being wheeled in a stretcher, so immediately your treatment is going to change right then and there. Okay, so when you talk about general examination, don't specify pre-operative or anything, but whether the patient is going to tolerate your treatment or not. So that is what you're trying to assess in your general examination. Can you go to the next slide? What are the grades of mouth opening is good in this patient? Would you expect anything? A tobacco chewer with a, would you expect anything? What is oral submucosal fibrosis? And when do you expect oral submucosal fibrosis?
Oral submucosal fibrosis, it is a condition due to the consumptions of an areca nut. Basically, the main etiological factor is areca nut. In this condition, there is a juxtaposition of a collagen in the submucosal layer. As due to the areca nut, there are the carcinogens that have an arecaline, they are the pro-fibroblastic, and they have various chemicals like tannins and procyanidins, which are pro-collagenase. So there is extracellular deposition of an excessive collagen and leading to submucous fibrosis.
Yeah. So when you say the mouth opening is 3.5, we know there is no oral submucosal fibrosis. Okay. So only if the mouth opening is restricted, as soon as we see that is when you need to substantiate why mouth opening is less. Either it is because of oral submucosal fibrosis or because of the tumor spread. So when the mouth opening is good, you don't have to mention that there is no features of oral submucosal fibrosis.
Okay.
Okay. Then how do you describe an ulcer under inspection? What are the subheadings? And how does it help you in your diagnosis?
Firstly, basically the site of the ulcer.
Okay.
Site,
Size.
size, shape is edges, margins, base of the
Pattern
ulcer.
of growth. Yeah. First thing that you have mentioned yourself is pattern of growth. That you have mentioned is ulceroproliferative. So if you see an infiltrative lesion, so what does it tell you? And when you see a, can you hear me?
Yes, ma'am. Yes.
Yeah. So what, based on your pattern of growth of the ulcer, does it give you a idea of what the pathology of the lesion could be? Yes.
Yes, ma'am.
So how would a verrucous lesion look like on the surface? Ulceroproliferative. What are the other ulcer growth patterns that you see in squamous cell? How would variants of squamous cell present like based on the ulcer, the pattern of growth of the ulcer?
Ulcers can be ulcerative, proliferative, ulceroproliferative. It can be infiltrative. They can be verrucous in nature. These are the patterns. These can be the patterns of lesion in the SCC.
Yes, sarcomatoid SCC is also one of the variants where most of the, how is the pattern of growth in sarcomatoid SCC?
It's mostly a proliferative pattern in the sarcomatoid variant of SCC.
Yeah, it's usually proliferative. There is a high submucosal disease spread. So you will see a lot of bulge around the ulcerative lesion. When it is a sarcomatoid SCC, you will see dilated vessels around the ulcer. And also in your history, there is usually a rapid growth. So that in the span of just 2 weeks. So all these will, so describing the pattern of ulcer will also give you a diagnosis of the pathological diagnosis of what it is.
Yes.
Okay. Can you go to the next slide? How do you measure mouth opening? You mentioned in inspectory findings are confirmed. So how did you confirm your mouth opening? So that you have measured it as 3.5 centimeters. So how did you?
Ma'am, I have measured it from the inter-incisor distance by using a routine scale, but ideally it should be measured with a vernier calipers.
Yeah.
But in my case, I have just measured the inter-incisor distance with a routine scale.
Okay. Can you go to the next slide? Okay. Anybody has other questions, clinical questions? When the skin is involved, what are the features of skin involvement, clinical features of skin involvement?
If the skin is involved, there is a gross involvement of skin which can be detected clinically, either in a form of a ulceration or a fungation of growth, or it may be appear as a superficial infiltration of the skin, in which there may be a local site in changes of inflammation, and maybe a loss of hair around that area might suggest a skin involvement. Or a
Then?
or a PUD changes around the puckering of a skin that can denote the skin.
Good. So remember your clinical DAS completely. Okay, when we talk about skin involvement, whether it is skin involvement in buccal mucosa or in breast, as DAS describes, the features are going to be the same. When there is superadded infection, only then do you see that classical redness, inflammation. Otherwise, you do see tumor edema, pudy orange appearance until there is a frank infiltration through the skin. So especially in this case, is it important for you to specifically look for it?
Yes.
Why?
Pardon, ma'am.
As I asked why.
Ma'am, involvement of skin will upstage my disease, and as the involvement of skin will upstage my disease by the T4A lesion, involvement of skin.
Yeah. Remember, the buccal fat pad is quite thick as you go posteriorly, but it's not the same anteriorly.
Yes,
So in a
ma'am.
buccal cancer, when the disease is anterior, skin involvement is way too early. So no matter how small your disease might look like, you always have to look for features of skin involvement.
Yes.
Okay, so go to the next. Next slide. So how do you want to, next one? Imaging, nothing is there for the patient.
Yes, ma'am. For this patient, I will just work up the patient in the form. First of all, I will order a biopsy so that I can just know what kind of region I'm dealing with.
How do you do a biopsy? Incisional punch, and where do you take the biopsy?
Ma'am, in a ulcerative proliferative growth, I would just do the punch biopsy from the most representable lesion of the ulcer, or maybe the most indurated part. And if I suspect if there is a more proliferative component, then I might do an incisional biopsy so that I can take the subepithelium, so that my pathologist can give an idea of a more detailed analysis of the biopsy report.
Do you take adjoining mucosa when you do a biopsy?
No, ma'am. Routinely, we don't do that. We have to take a normal adjacent mucosa.
In what cases do you do that? When do you take biopsy? From the interface of the mucosa and the ulcerative lesion.
Ma'am, in cases
When
of
you see, yeah,
in cases of early pre-malignant lesions like erythroplakia or any proliferative lesion, we just then in those cases we can take adjacent mucosa
when you are suspecting verrucous CA,
verrucous.
you always take the biopsy at the edge of the between the interface of the ulcer and the mucosa, so that the pathologist get a better picture of the deep, broad infiltration that you classically see in verrucous CA. Okay, when you take proliferate from repeated biopsies from the proliferative part in a verrucous, they can never ever make the diagnosis of verrucous CA. They will give you a diagnosis of probably verrucous proliferative leukoplakia or something. So for you to differentiate between that and an invasive verrucous CA, you need to take the biopsy at the edge. So when your clinical examination, if you see that the lesion looks verrucous, then most often you take biopsy, if possible multiple biopsy. You take it in the place where it is most indurated, and you preferably take it at a place at the interface between the ulcer and the mucosa. Okay. Then what other investigations?
I think there is a question in the chat, how to measure the depth. How did you measure the depth of the lesion?
So depth of the lesion, it's a histopathological parameter to assess. In the clinical examination, we'll just palpate the tumor thickness, what we can palpate, and we can just give an approximate idea of how the tumor thick is.
You bidigitally palpate the lesion to get an
palpation of the lesion as well as the bimanual palpation for the lesion and the skin, just to give an approximately idea of a depth of invasion.
Yeah, it's a thickness that we measure, not the depth of lesion clinically. So, okay.
So in biopsy, what do you expect? What type of histology are you expecting in this patient?
Sir, we have done a biopsy and it's a well differentiated squamous cell carcinoma.
So are there any other DDs, like any other histologies which are possible in this case?
So for a buccal mucosa lesion and that to be a malignant neoplasm, there are no other DDs, but there might be a minor salivary gland tumors of the buccal mucosa in which they have been punched out. They may seem look like a ulcerative, but they are morely submucosal and they are morely like a submucosal growths. But yeah, due to punched out lesions, sometimes they may mimic as ulcers.
So I think you said this case was well differentiated squamous cell carcinoma. Am I right?
Yes.
So what is the significance of grade here?
So differentiation.
Means I want to know whether it has any prognostic value or whether does it tell something else.
So the differentiation.
Why do they mention the grade of the tumor?
So it might be basically the aggressive. It just denotes the aggressive nature of the tumor. It may be a well, moderately, or a poorly differentiated tumors. But in the post-op settings, there are some studies which quote according to the grade they might add any adjuvant treatment or not. But still, these are under surveillance only. There are no clear-cut level 1 evidence to say that in such kind of poorly differentiated or well differentiated, there might be a additional benefit of adding any adjuvant treatment.
Will it guide your treatment in upfront setting? Suppose if this was a poorly differentiated tumor.
For the prognostic implications, it may guide our treatment is to prognosticate the patient ki the lesion is a poorly differentiated and we are dealing with aggressive biology. So it might chances of recurrence, or we can just prognosticate the patient according to that.
See, as such, it might not aid in your treatment planning as such. So when sir asked you, your outright question should have been that it has only prognostic value, at least for this patient. So what are the further investigations you would like to do?
Since this is a early buccal mucosa lesion, I would go ahead with the imaging in a form of a cross-sectional imaging of a contrast enhanced CT scan of a head and neck.
Yes, contrast enhanced CT scan of the head and neck.
Yes, ma'am.
What is the extent? How much will your CT cover, from which level to which level? What thickness will you ask for?
Uh, 5 mm thickness, thickness.
From what level to what level do you image a patient of oral cavity? See,
From skull.
you don't. To
Really from skull base to thorax to the.
your voice is breaking.
Skull base to thorax.
Thorax to what level? If
T4.
if I want to image only neck till. Hello.
Level of T4.
Okay. In this patient, you said that the tumor is very close to the skin.
Yes.
I can see all the extent of the disease. If I say I don't want to do any cross-sectional imaging, am I right or wrong?
Ma'am, initially in the early T1, T2 lesions, if all the 3 dimensions can be palpable, we can avoid imaging in such cases. If we are sure about all the 3 dimensions of the tumor, we can avoid the scanning. We can avoid imaging.
You don't. You specifically say you can avoid cross-sectional imaging, but you will still get an ultrasound of the neck. Neck has to be staged clinically, right?
For clinical staging, for the completion of my clinical staging, I can add a USG neck for the neck node status.
Yes. Do you have the CT scan of the patient?
Yes, ma'am.
So can you tell me which imaging will be better here for neck N0 neck? Do you know of any values, negative predictive value for USG CT? Do you think any modality is superior to anyone? If you're specifically asking about N0 neck.
Sir, in an N0 neck, the basically diagnostic accuracy of modalities like USG, CT, and MRI, or even a PET scan, they all have a sensitivity of around 60 to 70%. And so basically, they have all a diagnostic accuracy of around similar in case of an clinically N0 neck.
Okay.
What is the negative predictive value of PET for N0 neck? Can you hear me?
Yes, ma'am.
Yeah.
Sorry, ma'am. Sorry, ma'am.
What are the other? How do you stage neck? What are the methods of staging the neck? Preoperatively and operatively, what are the methods of staging the neck?
Ma'am, staging can be, according to the AGCC classification, we just need a just a complete clinical and radiological imaging just to complete our staging. And
see, when you say we want to stage the neck in N0, so preoperatively we have the imaging systems. So we have CT scan, MRI, PET, ultrasound with guided FNEC. Then we have sentinel node biopsy.
yes, ma'am.
And elective neck dissection. So these are the methods of staging the neck. So all of them, when there is an outright question of just staging the neck, you'll have to mention all and divide them into preoperative and operative.
Okay.
In this patient, I know that you said that the tumor thickness is 1 centimeters.
Yes.
Had it been much superficial, because he's a 45-year-old patient, would you advise sentinel node biopsy in this patient had the depth been much less, thickness been much lesser?
As we have evidence key doing elective net dissection versus therapeutic have an increased overall survival, but in this patient, it's a superficial. In case of very superficial lesions like T1 lesion with a depth of invasion around 3 or 4 millimeters, we can stage the neck by doing a sentinel lymph node biopsy, and so that we can just avoid the unnecessary neck dissections to stage the neck dissection postoperatively.
Okay. See, sentinel node biopsy, all the recommendations do recommend. If you look at the guidelines, you will see a sentinel node biopsy as one of the recommendations. But when you're answering, you will always say based on the setup that you are working. If you have the setup for sentinel node biopsy, only then you will advise for it. Otherwise, if you're not doing it routinely at your center, you can always say you will not give that option to the patient. Okay. Describe the lesion and show the lesion on the CT.
Ma'am, this is an axial scan, contrast enhanced CT of an head and neck.
Of cheek.
With a puff cheek technique, puff cheek. Basically, ma'am, there is just a asymmetrical mucosal thickening around the right buccal mucosa as compared to the left side buccal, left-sided.
Keep going down. Okay.
And on further discussion with my radiologist, they have given the depth of invasion of around 8 millimeters, and they have also mentioned that the involving the buccinator muscle is involved.
So is depth of invasion measured by radiology accurate? Does it correlate well with the pathology? And if it does not, does it overestimate, underestimate? What does it do, depending on the modality?
So since the depth of invasion is a histological parameter, so there is still no still any measurement to measure it accurately preoperatively. Radiologically, there have been studies in which they have quoted radiologically, and there have been studies which have quoted radiological depth of invasion preoperatively and after posteriorly. They have been synonymous, but still level 1 evidence is not there. What if it overestimates or underestimates? Sometimes, most of the time, it just overestimates due to the peritumoral inflammation around the tumor.
Yeah, please carry on, Dr. Sanskriti. Yeah.
And in this case, how do you measure it? How did the radiologist measure your? You said depth, right?
Yes, ma'am.
Yeah. How did they measure it? Radiologically, how is depth measured? Although it is a rough estimate, I don't think I can use the cursor, but you draw a line on the normal mucosa. And I don't think I have access for that. You draw a line along the normal mucosa, so that will cut your tumor into proliferative and infiltrative part. Do you understand? So the proliferative, when you measure the end of the proliferative part to the most infiltrative part, it will give you tumor thickness. So when you want depth of invasion, you will only measure the infiltrative part in early buccal cancer. So here you do not see a significant knot in this cut. Probably if you come back a little bit, you might see some kind of a proliferative component. So in those cases, you will see that interface between the normal mucosa and your ulcer. So you draw a line, and from there you measure either you want your tumor thickness or depth of invasion. As rightly said, it does most often overestimate because of tumor edema, or if there is any infection, especially there was so much of necrotic lesion at the base of the ulcer, it is more likely to overestimate. But however, here you can see that the lesion is also abutting the skin anteriorly.
Yes, ma'am.
So although your depth is 8 mm, it is surgically, it's extremely close to the skin.
Yes, ma'am.
So anybody else has questions? Hello?
Yeah. No, I think there is less time. I think we can go to the management also. I think there are only 10 minutes left.
Yeah. Okay, fine. How will you manage this patient?
Ma'am, I would like to offer the patient the curative intent with a single modality treatment. That is the surgery. My surgery would be the buccal mucosa composite resection, in which the wide excision of buccal mucosa plus skin excision with a selective net dissection level 1 to 3, and plus appropriate reconstruction using a skin lined any faciocutaneous flap, mostly a radial forearm flap.
Okay, so if you describe this patient mucosal defect, what is your extent of resection mucosally? What is your extent of resection at soft tissue? And what is your extent of resection at the skin? You can put the clinical picture and describe if you want. How much margin will you give?
Just a minute, sir. Sorry to interrupt. Shweta, you can continue the discussion for another 15-20 minutes if you want. So there is no time limit that it has to get over by 7 o'clock.
Okay. Thanks, Asim.
Ma'am, for the buccal mucosa margin, my margin would be a 1 centimeter mucosal margins all around the tumor. And as the skin is closed, so I would be just taking the skin as a margin. I don't want to, I will take a skin as a margin, and through defect, it will be around around 3.5, around 4 centimeter defect involving the commissure and with the external skin.
Can you put the clinical picture?
Okay.
Mucosal margins is something that you can see. So show me how do you mark your skin incision on this patient?
Incision. I will just whatever the extent of lesion I am seeing, I will just palpate the lesion if there is any induration palpable around the lesion, and from that I will just mark. I will just mark around 1 centimeter all around the mucosa, as my lower GBS and upper GBS are free. So I don't be taking any bony margins along with that. So just around a 1 centimeter will mark around 1 centimeter all around the tumor.
Yeah. See, here in this patient, it's quite straightforward because the mucosal disease is the major disease that the patient has. You don't see any soft tissue standing into the buccal space either. So
Yes,
your margins of soft tissue and your skin is going to coincide well.
Yes, ma'am.
So when you're marking your skin, you palpate the thickness, you palpate where all there is induration, you first mark the tumor. From there, you mark 1 centimeters. So apart from what you can palpate, what are the other features on the skin that you will take into account when you're taking margins? Do you take pudy orange as disease? Do you take redness as disease?
Ma'am, as in this case per se, there are no significant clinical changes on the skin. So I would just take a tumor thickness along the margins and will just excise that amount of skin margin that is adjacent to the only the mucosal lesion. In cases when there is a suspicious involvement of skin and we are not taking that skin as a third dimensional margin, we might have to take a margin from that skin area also. In cases like there will be a locally changes in the external skin or a puckering of skin or a POD or any changes around the skin, then we might have to take a margin from that skin also.
And you also have to look at the dermal thickening on your CT scan. Here you do not see any dermal thickening. Again, I cannot show you, but lot of times you can see dermal thickening on your CT scans. So when you see that, you have to make sure that you give more than 1 centimeter margins in those cases. It might not hold good in this patient because this patient doesn't have it.
Yes, ma'am.
And what kind of reconstruction would you do?
Ma'am, as this is a 45-year male and my resection would be around 3.54 centimeter with a buccal mucosa composite resection and with the involvement of a commissure also. So I would just offer him a skin line myocutaneous flap, most probably a radial forearm flap, so that he can have a post-operative good functional outcome as we are as the oral commissure is also involved in the margins.
What are, apart from radial artery forearm flap, what are the other flaps you can use for reconstruction?
Ma'am, for reconstruction, apart from flap, we can have a local regional flaps like submental flap. But still, there is a debate for an oncological safety point of view, as this lesion will be around this first echelon draining will be a 1B. So that would be an option, submental. And secondly,
Yeah. Tell me. Other flaps.
Secondly, ma'am, we can use a supraclavicular artery island flap.
Okay.
Or an infrahyoid flap.
See, you have already described saying faciocutaneous flap. So all the regional flaps that are faciocutaneous are the only flaps that you can use for this defect. Infrahyoid is not a faciocutaneous flap. It has muscle component. Yeah, it's myocutaneous. So you cannot use that. Submental flap has significant fat. Even if you want to use it, even if it is oncologically safe, it is not, you cannot bipaddle it. So to bipaddle a small defect like this, you yourself have already answered it saying faciocutaneous. So you can use scalp or you can use forehead. I wouldn't advise that. I wouldn't advise that. Radial forearm is the best choice of treatment for this patient. Then we didn't talk about management of the neck. You said you will do from level 1 to 3.
3, ma'am.
Would you address level 4?
Ma'am, since this is a clinically N0 neck, and in cases of oral cavity, most of the lymph nodes involved are the level 1, 2, and 3. Around, we have a data from an old paper like patterns of spread from an upper digestive tract from a Jatin P. Shah sir. And we also have a prospective study from a Tata in which they have addressed a prospective study of a 583 patients, in which 91% of the lymph nodes can be addressed in a level 1, 2, and 3. And the involvement of level 4 is around 4.8%, less than 5%. And level 4 and 5 are never, there is no incidence of any skip metastasis. And they are always involved if the preceding neck nodes are involved. So in the buccal mucosa case, I would just do a 1, 2, 3. And if it would have been a tongue case, in that there has been incidence of level 3 skip metastasis around 15%. So in that scenario, I would have included level 4.
Yeah, good. Even in those retrospective studies, when the tongue maximum skip metastasis was seen in tongue than in buccal cancers. So your justification of doing level 4 in tongue is accepted. Then anybody else? Dr. Satya, Dr. Shweta, do you want to add on anything?
Yeah, so I just wanted to ask, in this patient, can you think of any other curative intent treatment that you can offer besides surgical excision? What would that be? Whether you will offer it in this patient, is this ideal, or in some other patient? And what would be the pros and cons of that treatment as compared to surgical excision?
So apart from the basic surgical modality, we can have a radiation as a treatment of choice, radiotherapy. In this patient per se, as the lesion is a small lesion, around a T2 lesion, and patient as an oral commissure is involved. So basically, on a surgical aspect, we are just compromising the oral competency of the patient, as it will have a devastating effect on the oral competence. So in this selective case, we can have a role of an interstitial brachytherapy in such kind of patients in which the lesion is around the lip or a buccal mucosa lesion just involving the commissure, and we just want to preserve the functional outcome of the patient. So in selected cases, maybe a interstitial brachytherapy can be considered.
Will you do it in this case? Will it be your preferred modality?
So it won't be a preferred modality for me for this case. I would go for a surgical treatment, as basically I would be addressing the neck also. So I would preserve radiation as a later for a second in a second primary or any other tumors. But for this patient, I will go for the surgery, definitely surgery.
So combined with brachytherapy, do you think that neck can be addressed in some way, including brachytherapy?
Sir, in this T2 lesion, along with the brachytherapy, we can give a external beam radiotherapy BRT to the patient, and it can be given in around 45 to 50 grays, and we can give a interstitial brachytherapy boost for the primary tumor.
Sarbani madam has asked, in such a case, what would be the incidence of lymph node metastasis? So what would be the rate of occult lymph node metastasis? Suppose if you go ahead and do an elective neck dissection in this patient, like you said, level 1B, 2, 3, what are the chances of neck coming positive in pathology? What do you think?
So the incidence of in the early buccal mucosa lesions, the incidence of occult metastasis is around 23 to 24%. It just varies between 20 to 30%.
30%. Don't you think 30% comes from comes from tongue series? If you're quoting the N0 data and the central data, both are predominantly 80% population of tongue. So is there any buccal mucosa data?
But around 23%.
In fact, the ICOR study from our institute actually quotes it as quite as somewhat lesser. It's not for gingival tumors, which actually gave the AJCC staging. So it's around 15%. That's the again heterogeneous population. So it's not it does not go beyond 20% in early buccal mucosa. So would you like to combine this brachytherapy with, suppose you want to maintain the oral competency of the patient, and the patient insists he doesn't want to undergo surgery because of cosmesis or functionality. Do you think that brachytherapy can be combined with neck dissection? You do elective neck dissection, send for frozen, it comes negative, and then you ask your radiation oncologist to do a brachytherapy. Do you think that's a good idea?
So it is a good idea, but I would like to offer a single modality treatment to the patient in such initial stage cancers, as if the patient, if it's not a resource constrained setting, if we are able to provide a free flap, that is a radial forearm, to the patient, I think the outcome will be as good as compared with a radial forearm flap. Even
in terms of function or cosmesis or both?
Maybe both functional and cosmetic outcomes. Maybe a functional outcome would be lesser.
Okay. So are you aware of any data regarding that? I know it's probably too much to ask, but there is a head-to-head comparison which say that possibly, again, all retrospective, but possibly in well-selected cases, the functional outcomes are possibly better if you do good brachytherapy. Again, all biased and retrospective data. But yes. So yeah, that's what I wanted to drive on the point, that brachytherapy can be considered an option in this particular patient. Again, we can debate about regarding how to address the neck, whether to address the neck and everything. But to try just to make the point that one of the modalities, especially particularly in commissural tumors, is brachytherapy.
Yes, sir. The selected tumors, we can give an option of brachytherapy.
So, what was the post-op histopathological staging for this patient?
Sir, we have not operated this patient. We have just planned in. Patient is not being operated.
Okay. So, let's say hypothetically, this maybe we can assume a different patient. It comes out to be a T3N1 disease. So, what will be your next step then?
T3N1 disease. Any lesion, if there is a T3N1 disease, then I would be, after surgery, I would be adding a adjuvant treatment in the form of radiation to the patient. Since it's a high advanced disease and is node is positive, so we might add adjuvant radiotherapy.
Okay, and any form of chemotherapy? Is it required?
Sir, I would have to see the margins of the resected tumors, and if the margins are all free of tumor more than 5 millimeter, and there is no indication, there is no any in the histopath report there is no evidence of any extranodal extension, I won't add chemotherapy as an adjuvant treatment.
So what is the best treatment for a margin positive disease?
Sir, there have been studies. It's better if we can revise the margins. It's
Yes.
better. It's better.
So what are the problems with re-excising the margin?
If we have done something like a lab reconstruction, or we have reconstructed the lesion, then the revision of margin would be very difficult in those scenarios.
In this case, might not be too much, because your orientation of the rest of the tissues might more or less be static even after your surgery. But in a case like tongue, or in advanced cases in where the depth and the infiltrative margin is not regular, in those kind of cases, it is extremely difficult for you to go back and revise your margin, because the margin that you revise might not be the representative margin. Okay. So what is the evidence for adjuvant treatment, CTRT, concurrent CTRT?
We have two studies like EURTC 22931 and RTOG 9541, and these both studies have added a adjuvant chemoradiation to a chemoradiation, and there was a combined study of defining risk levels from combining these both studies, and after combining those both studies, we came to a conclusion that the extranodal extension and the microscopic involved disease are the poor predictors, and there is a role of adding concurrent chemoradiation in these two selected scenarios.
What was the benefit? I mean, no, continues.
No,
I think
sorry. So you said true trials RTOG 9501 and EORTC 224.
Yes.
What was the definition of margin same in both the trials when we are talking about microscopically positive margin? In other words, I'm asking what is called as involved margin. So that's what my question is.
Basically, the histological margin is more than 5 millimeter. It's free. If it is if 1 or less than 1 millimeter, it is involved, and the margin between 1 to 4 millimeter seems close margins.
So this is as per. And are there any other definitions? And is it very standard to use it?
So there was a meta-analysis by Caroline Anderson, and they have been during meta-analysis they have been they proposed this definition, and
so actually NCCN actually mentions less than 0.2 as the positive margin, not 0.1. The other things are as per the NCCN guidelines, but if you see the NCCN guidelines, it's actually 0.2.
What was the Dr. Devendra, what was the difference in the inclusion criteria between ERTC and RTOG? I think that is where the question actually started from. Sir asked, no, what was the definition of margins difference? In the RTOG trial, it was the positive margin, and less than 5 millimeter margin is what was considered as high risk in the ERTC trial. Okay, so there is a difference in the definition. So when they did a pooled analysis, what was the percentage of reduction in the risk of relapse? when you added adjuvant treatment?
Sorry, ma'am, I'm not aware of.
The risk was almost, reduction in the relapse was almost 42% in the pooled analysis. Okay, so in this case, it if the skin is quite close, so there is all the more chance that it could be T4 in this patient. So whether ENE, microscopic ENE positivity also can be a chance. So whenever you see such a patient, you should know about adjuvant treatment completely. So what is the evidence for adjuvant RT alone?
For the adjuvant RT, I'm a high stage disease like T3 and T4, and two or more positive lymph nodes, 2 and 3, and
Which trial?
uh, initially in I think in 92 there was an article from a Lester Peter, and they have defined the risk factors and the dose of adjuvant RT to be given, and in that trial, and they have just scored on the basis of their clinical and pathological parameters, and they have graded according to the point system, according to the clinical and pathological histopath report, and they have divided the patient into high, intermediate, and low, intermediate, and high risk category of the patient.
So Lester Peters trial was not comparing observation to adjuvant RT. I think Dr. Samskriti was asking that only.
Yeah.
So it was comparing various dose levels for various risk groups of patients. So it was not a head-on comparison. In fact, the only randomized trial comparing adjuvant RT to observation is actually a small one that comes from Katak, Acharya Hariyar Katak. That remains to date the only trial which shows benefit of. It's a small trial conducted in somewhere around late 80s or 90s, and it's I think Sarvani madam has written, Mishra et al, and that only is the only small trial which shows I think probably 70 or 80 patients, which shows some benefit of adjuvant RT. Otherwise, there is no direct comparison of observation versus adjuvant RT for early or locally advanced oral cancers. Most of the evidence comes from retrospective studies. Again, Lester Peters, Kian Ang's trial all have tried to ascertain various parameters in which patients might benefit from adjuvant RT, adding adjuvant RT, but those are all more of a subgroup analysis from a cohort of patients. They are not direct comparison. So Asim, I don't think University of Virginia was also a randomized trial. Wasn't it a cohort study?
Okay, Dr. Devendra, how will you follow up the patient?
After surgery, if there is no need for an adjuvant RT in this patient, I would like to follow up patient for every 3 monthly till the 2 years, and after 2 years till 5 years, every 6 monthly, and after the 5 years, yearly follow up. And in case of adjuvant treatment, if indicated according to a post HPR report, and I would initially, after the completion of its adjuvant treatment, I would like to follow him for initially 6 weekly and up to 3 months, and then we can follow the same.
So what all basically you look during your follow-up visits?
So in the follow-up visits, first of all, the nutrition status is basically his mouth opening. If patient is able, if basically a rehabilitation of the patient in order of a mouth opening, if patient is able to open his mouth, or if he is doing exercises for the same, his shoulder physiotherapy, as we have doing neck dissection and speech swallow reference for a routine, and every visit will be a complete oral cavity and a examination of a primary site plus a Hopkins and a neck node status of the patient.
And considering since he was a tobacco chewer, so would you be able to advise him for something?
prevention, just for his prevention manuals, like who just quit counseling about the quitting tobacco.
Yes, so it's very important during follow-up, as clinician or as primary oncologist, wherever the patient goes. Our aims during follow-up is to detect the recurrence or second primary malignancies, to help him in the rehabilitation, like you said, to manage the treatment-induced toxicities, as well as to advise the patient for the lifestyle changes that act as a risk factor for future recurrence. So these 4 points we should all keep in mind while you are following up the patient. So so my last question to you is, if let's say the patient has received adjuvant RT, so anything else you want to do in that patient in the follow-up?
Uh, there is a acute and late toxicities of radiation, and for acute toxicity like mucositis, xerostomia, and in the late complication around after I think 8 months, a patient, as the neck will be treated with the there were radiation exposure to the neck, patient can be hypothyroid due to radiation induced. And so I would like to add a thyroid function test for the patient. They might not be hypothyroid due to radiation.
Okay, good.
I think we can conclude. I think I have no questions.
Yeah, even I think we can do.
So thank you everyone for the joining us. Thank you Sanskriti. Thank you Dr. Satya. Thank you Shweta, and thank you Chokar sir for the wonderful talk. And we'll meet once again on 8th of February. The topic will be on sentinel node biopsy. And on 9th and 10th of February, we are hosting an event that is Mahamana Oral Oncology Update. We will be inviting only 20 participants for offline training. So it is to be held in the operation theater and in the hospital. And we'll also have some lectures that will be available online. So all of you are welcome for that. If you have anybody who is interested, you may please let them know so they can come offline here in Varanasi. And thank you once again. Thank you all for joining.
Yeah, thanks, Azim. Thanks, everybody. Thanks for the invite.
Thank you, sir. Thank you.
Thanks, Asim.
Thank you.
Well done, Devendra.
Thank you, everyone.